Thank you all very much. And now I can say with great confidence, and now for something completely different. What I'd like to do today is really share with you, and I really want to thank you for this opportunity. I want to thank the planning committee and the hosts here who have been so great, and I'm really looking forward to the chance to share some of our ideas and some of the work that we've been involved with over the last probably 12 years at Children's. Trying to move the needle a little bit in terms of simulation and look at the communication and relational skills and how we incorporate those into simulation. I have no disclosures to make. And I'd first like to acknowledge my collaborators, especially Dr. Robert Trug, who is an intensivist and an ethicist, and we worked together very closely over the last 10 or 12 years on our work. So just to summarize a little bit, traditionally, simulation really has been the purview and has focused on technical skill acquisition and really how to manage crises. Really, we have a lot, we're in debt to our military colleagues who really were at the forefront of simulation. And here you can see a mannequin with, in camouflage with his helmet. And we can see some people in terms of their work with simulation and practicing. This, and now I got to tell you, for a psychologist, this is a stretch. But some of these slides, when I was going over them, my assistant actually thought I had the wrong slide set. But what the point here is that this is a combination of an actual person with the partial task trainer strapped right on so that it feels more realistic, so that it's not only practicing the procedure, but also interacting with the patient, as it were. And so, again, the demands on the learner go up considerably. A lot of emphasis in simulation on team training. And oftentimes when we talk about communication in simulation, it's about the communication within the team, not necessarily the communication with our patients and families. So that's the part that we've really focused our attention on. It's another photograph in terms of the operating suite, and we can see a full operating room and the team leader. Lots of, go to the simulation, big simulation meetings in terms of making this realistic. So for our surgery colleagues, being able to practice their sutures. A whole field that's come out called moulage, which is just how to make incisions and wounds look really realistic. So these are the developments, again, how to make blood look realistic. So these are the kinds of things that when we go to the simulation meetings, this is typically probably about 85% of what we see. Now, here we go, something we can relate to. This is not only are we having mannequins, but now we're going to have baby mannequins and women that can practice. And I remember when I went through the exhibits and they said, here, you want to deliver a baby? And I said, oh, I'm not sure I'm really ready for that, but I did. And I actually learned a few things. So again, there's so many developments going on. What I want to draw your attention to, let's see if I can find it here, is right up here. There's also something happening here, okay? She's got a wig on, she's got glasses, so there's some humanization in terms of what's happening with the mannequin, okay? Now we have our baby sims, and again, this is in situ, meaning that we're not in a simulation lab per se. We're right there in the unit. Many of our simulation suites are embedded right into practice so that, again, that realism is very important for the learners. Again, our PD sims and the pediatric patients and our military colleagues. Okay, now, some of you might recognize some of the people in this slide. Do you? They're actors from House. Yeah. This woman, this guy, she's an actress. And some of you might recognize him back here. This is Amitai Ziv. And this was actually a photograph that was taken in Israel at their big sim center. And so what I want to draw your attention to is what's happening here. okay? So now the mannequin is, we're holding the mannequin's hand, we're emotionally supporting the mannequin. So this is different, okay, than the battlefield scenes a little bit here. So this is, I think, a new direction for simulation in terms of us really thinking about the communication and relational and the emotional support of our patients. In addition to the medicine that's keeping them alive, how do we support them, provide them the information that they need? I'd like to draw your attention to, in August of 2013, a recent issue of Simulation in Healthcare came out. And I've been on the editorial board really for a very long time with the journal. And there are some really interesting things that are happening in our journal, and I think are starting to track the progress. You're not supposed to see this. Don't worry about it. I'll tell you about it. But some of the lead articles, okay, in August were about standardized patients and also how should we be training actors. So this is quite a bit different. Now down here we've got some of our articles around ECMO and CPR, sort of more traditional articles for our simulation in healthcare. And then down here with the two cases, quite different. I want to show you one of the titles of the article is From Beginning to End in Anesthesia. And this article is really interesting because it's not only handling a difficult airway, it's how to do informed consent, how to handle a difficult airway, and then how to deliver bad news to the patient. So I think what's happening is we're really expanding the whole scope of what simulation is doing. The other case study that was in the, let's see if I, oops. Oh, I'll get to that in a minute. But the other case study was around a suicide attempt. So again, just the content is changing, but also just in terms of that relational learning, there's quite a bit that's happening, quite a bit that's changing. So I put this little visual graphic in here, and my point is for every procedure, every surgery, every intervention, there's often a conversation that happens at the beginning of that, at the front end. There's also conversations that happen at the end. So we might think about informed consent early on, explaining the procedure to the patient and family, answering their questions. We go ahead, we do the procedure, we have the intervention. It either goes well, it may not go well, there may be complications. And then we also oftentimes have another conversation. So for every procedure, there theoretically could be multiple conversations. So I like to think of these conversations as the bookends for the procedures and the interventions that we're doing in the ICU. This is something that we like to talk about in terms of the change and how more and more of our partners are really starting to incorporate what we call this A to Z model, so that it really is how do we talk with the patients before, during, and after. In terms of the simulation education, most of our resources have really been devoted to technical skill acquisition, very, very small percentage in terms of the relational learning and communication skills. So what I'd like to do is just quote to you from the ACCCN, which is the American College of Graduate Medical Education. They have defined 6 core competencies for physicians. 2 of them directly relate to communication and professionalism, so fully a third of the core competencies. The medical interview, if you will, can be considered the most commonly performed procedure in medicine. It would be the clinical interview, much more common than the interventions that we're going to be doing. Again, if you think for every intervention or technical skill, there are several conversations that it's embedded in, the bookends, if you will. And Matt Lipkin has done some work, and he estimates that between 160,000 and 300,000 is the number of sort of medical interviews that a physician is going to complete over the course of his or her professional life. So what is it about the communication that's so important? Why does it matter? Well, if you've ever been a patient, you probably don't have to ask that question, but this is the thing that people often remember. What we know is that people they may remember the words, they may remember how you treated them, oftentimes is what they remember. And they oftentimes will remember how you made them feel. Maya Angelou, the great African-American poet, will say, I may, not remember the words that you say, I may not remember what you did, but I am going to remember how you made me feel. And so when we start to talk about things like patient adherence, symptom improvement and management, general health outcomes, and also satisfaction with the care that's provided, not only for the patients and families, but also as care providers, these kinds of parameters can be really, really important, and they can be a tremendous source of gratification in our work. Now, on the flip side, ineffective communication has been demonstrated, especially in our litigious society, the American society anyway, has been directly associated with increased malpractice claims and suits, as well as medication errors. So there's a litigation risk that comes with poor communication. When we talk about learning how to do these kinds of communication and relate to our patients, explaining things, supporting them from an emotional perspective, I'd like to quote a fourth-year medical student, Brody, and this was published in the New England Journal of Medicine. And he says, in medical school, we're taught to follow a script. But, as we all know in this room, the script ends. Okay? And he says, just like that, I was in over my head. I had no script. Only clinical judgment, that perplexing skill that can't be reviewed in morning rounds or diagrammed on PowerPoint slides. As he said, I was good until the patient asked me a question. And then he was off script. And that's when he started to say, well, wait a second, I better learn some other strategies here. So what we've developed over the last 10 or 12 years at Boston Children's is our philosophy of learning communication relational skills. And we like to think of it as a one-room schoolhouse. And the reason is because, well, let me give you the rationale for why we do the one-room schoolhouse. So this is from the New Yorker. So these kinds of issues are not lost on the public. So here's a fellow, obviously lots of credentials, and he's basically saying, so there's no easy way I can tell you this, so I'm sending you to somebody who can. And this is what I found over and over and over again. I'm a nurse and also a psychologist in our PICU. And what I was finding is people would say, can you just come into the meeting with us? Even if I wasn't saying anything. There was something about having somebody that was just there in case, to help bind some of the emotion, to maybe follow up afterwards, this kind of thing, to look at what the nonverbals might be. And there was just this sense that I had that people felt not so capable in this area, and definitely not very confident. So we took it upon ourselves to try to change that, and that's what our one-room schoolhouse is all about. So that we, in our program to enhance relational communication skills, what we call it, PERKS, we offer half-day, full-day, even hour-long sessions, workshops, and the one-room schoolhouse is really essential, I think, to its success. We always train across interprofessional learners and also across experience levels. Some of the most important learning comes from the people that are closest to the bedside, obviously, but also some of our novice learners. I can remember doing a PERKS NICU session, and there was a physician who was just talking about how difficult it was and how upset he used to get when patients, mothers in particular, would smoke and then come back to the NICU, and he said, I tell them over and over and over again how dangerous this is for their babies. And, he's just, again, trying plan A over and over and over again. It's not working. And there was a nurse who had been out for 2 months. And I asked if anybody had any ideas, because he looks to me and he goes, well, do you have any, bright ideas how to handle this? And, I was smart enough to say, wait a second, there's about 20 people in this room. Let's just see what the other advice is around the room. Again, the one-room schoolhouse. And this nurse with about 2 months' experience sort of semi-raises her hand, and I noticed that, and I said, please, you have something to share. And she said, well, I'm at the bedside. She says, I'm young. She said, I've only been here for 2 months, so I have to work really, really hard to earn people's trust and their respect. And she said, I have worked with patients, and when they come back smelling like smoke, and she said, this is what I do. She says, I take a clean blanket, and before I hand the baby to the mother or the father, what I do is I put a clean blanket over their shoulder. And I explain to them that before I give them to hold the baby, that I really want to make sure that it's clean. And, you know, I notice that their clothes smell a little bit of smoke. And I don't want that to, the baby's face to be right next to that. And so they look up and they say, you mean that can hurt the baby? Smoke, you know, like even the residue of the smoke or that I'm smoking? They don't make that connection until it's, now let me put this down so that you can hold the baby. And there was this sigh, and that was that learning that happened that I am sure that if there were all veterans, we probably never would have gotten to that. So I use that as an example because it really was sort of a transformation and a great shift in terms of the learning. And it also admitted the learning of somebody, a novice learner, that we all had something to benefit from. We use professional actors, and I'm going to be showing you a clip in just a little bit, who really are our tools, our educational tools. They are expert at titrating emotion, and they really can hold the characters for us and really help us in terms of practicing these communication relational skills. We debrief, we show the feedback, people get a chance to talk with the actors, and I would say it's not a stress-free environment to be in the PERKS program, but it should be risk-free. People should know that they're not going to be humiliated, they're not going to be embarrassed, okay? We're all there to learn together. And the other thing I think that's made the program helpful is that we have interprofessional faculty as well. So we always teach with physicians, psychosocial staff, and also with families. We teach with veteran family members who have been up in the NICU, up in the PICU, and they're not volunteers. We pay them because it's their time, and they work very hard with us and our full-fledged faculty members. So one of the things that we like to do, embed in our enactments, our realistic enactments, are some challenging questions that come up all the time for clinicians. Things like, what would you do if this was your child? Now that's one of the ones that, again, we may know what not to say, but we're not really quite sure what to say. All right? Again, that would be that guy sitting there. I'm going to send you to somebody else because I'm not quite sure how to answer that one. All right? And are you a parent? Again, for our novice practitioners, this can be stressful for them. They're not quite sure what to say. How about, how much experience do you have with this? How many surgeries like this have you done? Or how many of these procedures have you done? And I can remember doing a PERKS anesthesia where there was a guy, it was his second day on the service, brand new, newly minted anesthesiology person. And the patient, he's wheeling him down. He says, well, how many of these surgeries have you done? And the senior person right there said, well, between the two of us, about 25 years experience. She didn't say, I've got 24 and a half and he's got 2 days. I mean, she did not do that. So we learn about the team, okay? How much hope should you have? There are questions that are not, that don't have answers. I mean, there are questions, what I call with the capital W questions, existential questions that we get, in addition to ones that are about information, questions that may not have any answers. What kind of a God would let a child like this suffer? Now, you're at 3 o'clock in the morning by yourself. You're not quite sure how to answer that question. Or you may realize that that's unanswerable, okay? So these are the kinds of things that we practice. How about, have you ever seen a miracle? Anybody ever been asked that question? Yeah, have you ever seen a miracle? Well, if you haven't, it might be down the pike, okay? So, if you had to remember anything about the PERKS program, I like the Wizard of Oz philosophy, okay? Everybody know the Wizard of Oz? I'm dating myself a little bit because there are some people who have never heard of it, so I'm glad that you have heard of it. I like to think of some key ingredients when we hold these conversations with our patients and their families. On the left, remember what the lion was after? What did he want? He wanted courage. So never underestimate the courage and the leadership that it takes to hold these conversations. It's much easier to delegate it. It's much easier to be around the bedside less. But courage is an absolutely essential component to holding these conversations. The second one, what was our scarecrow friend after? Brains? You probably got that covered. If you're in the room, you're probably good. But this is your problem solving, your clinical expertise. What Peter was talking about. You pull your experience, okay? So brains, the next key ingredient. And then Tin Man? heart. So these are the three components, these three key ingredients I like to think of with our communication and relational skills. So if I had to put it on one slide, you know, what are people learning in these programs? Well, first of all, really important to ask the family, you know, what do you know? What do you understand? What have people told you? That can be less stressful for parents. Otherwise, they may think that you're quizzing them. If you say, what do you know? They may feel immediately inadequate, especially people who do not have a lot of sort of healthcare experience. So I often will say, well, you know, what have other people told you? It's just a softer way of getting at the same information. But what's important to you now? There are some things that we'd like to be talking about. We have an agenda for today, but I'm sure there are things that are on your mind. We want to make sure that we get to those. So that mutual agenda setting for any kind of a meeting, a bedside chat, what have you, speaking frankly and honestly, avoiding medical jargon to the extent that you can, and our actors will pick this up immediately and say, well, what do you mean by that? So again, people may, again, what we consider, you know, the norm for vocabulary and what lay people is can be very, very different, and that's where our actors can help us. Probably one of the most important things you can do when holding these conversations is to simply slow your rate of speaking. Now, this has two effects. First of all, it helps you to regulate yourself, which is always important. And secondly, when people are under stress, you know, they don't remember as well. They often need a little extra time to process, okay? You can certainly do diagrams. You can bring in models. People love it when people do pictures. And there's another thing about a picture. If somebody takes the time to draw something out for you or to write the name of something, it's evidence that you care. And the other thing is that they take it with them. My son had quite a bit of surgery when he was younger, and I still, to this day, have the photograph, not the photograph, the picture in the surgeon's hand of what the procedure was going to be. And that's not uncommon. People will keep that. It's dog-eared, it's yellowed, it's folded up, but it's in the folder. Okay? And they may come back years later and say, I remember. Okay? So these kinds of evidence that you care are very important. And again, allowing silence and tears in these meetings, if that's going to happen, anger, frustration, et cetera, and to, again, be able to distinguish your feelings and recognize them from the patient's. All right? This is just a photograph of one of our, two of our actors on the left-hand side and one of our physicians. And there's a lot that you can tell just from this photograph. I didn't want to have the words because, again, sometimes the patients don't even remember the words. But you can see that she's leaning in. She's actually touching the mother's knee. This is the actress here. She's got some facial flushing because, I mean, it felt very, very real to this physician. And this was a physician who for 25 years has been a high-risk ultrasonographer. And she was telling this couple, unfortunately, at 12 weeks, that their baby did not have a heartbeat. And so they're getting that news for the very first time together. So what is the value of these actors? You know, what do they bring to the mix? First of all, realism, the importance of the actor feedback, as I've tried to highlight. They do provide us with a layperson perspective in terms of language, and they are important for what they don't have. They don't have a previous relationship with the learner. And that's very important in simulation, I find. They don't have the medical knowledge. The depth of emotion that they are able to bring and we're able to titrate in our sessions, as well as the role of improvisation. They follow the lead of the clinician. They are not scripted. So here's a couple of quotes from our learners. This is a paper that's under review. One of our learners said, the actors are outstanding proxies for parents in difficult situations. They combine the emotional and spiritual truth of the moment with a safe offering of its reflection to the participants because they had asked a spiritual question, and the actors were able to go there. So again, taking simulation to sort of new heights. A faculty member, in terms of the depth of emotion, the actors frame the teaching in the emotional moment of the enactment, not through a subjective judgment from the outside, say from the inside out. And a faculty member said that the actors portrayed true human emotion in times of stress and anguish. In terms of the role of improvisation, feels very real to the learners, and they like this idea that they have to think on their feet. Okay, they don't quite know what the actor's going to, or the mother, the father, the patient is going to ask next. And from a faculty member's perspective, and faculty members, have to hand over some control when you have an improvisational actor, because they're going to take it in certain directions. So you've got to trust that process. But this faculty member felt that the actors were able to capture the participants so completely that they really sort of lost their defensiveness. They forgot that they were in a simulation, and they became themselves. And what happened as a result of that is that they really revealed a part of them that might otherwise not have been revealed to them or to the team. And so later in the debriefing, the actors are actually able to comment on that and tell them, you know, what it was like to be with them in that room, what worked, what maybe might be a nice learning edge for them. So that feedback is considered especially valuable to the learners. So what I'd like to do is show you just a brief film clip, and Peter's going to recognize this. This was a project that we worked on together. This was the New England Organ Bank in Massachusetts. And we were tasked, our hospital is a very big transplant center. We were not doing, frankly, as well with organ donation. And so we were asked if we could develop some simulations to help with our learning within our institution. And so we developed a case of Danielle Bartlett, who's a 7-year-old little girl. Unfortunately, she was a victim of a near-drowning incident. It was at a family pool party, so both parents were there, but the father's on the grill and the mother was running around with the party, so unfortunately, they found their little girl floating in the pool. On day 4, neurological exam was consistent with brain death, except that Danielle developed shallow respirations at 40 breaths per minute, about 2 minutes into the apnea test. The intensivist has already explained to the family Danielle's poor prognosis, and the family has met with other families and also a priest who was very important to them, and they have agreed to withdrawal of life support. So Danielle was a potential candidate for donation after cardiac death. And so what I want to share with you is the way that we've transformed simulation, and I want to take you, let's see here. Let me just tell you some of the questions that we embedded and we coached our actors. Okay, so all of these questions, you're not going to see all of them, but these are the kinds of questions from a communication perspective, but also from an ethical perspective that are embedded into the actor's portrayal. You really think that withdrawing the ventilator is the best thing to do, right? You're not rushing just to get her organs. Okay, so we have to respond to that. Can you guarantee us that somebody is going to get Danielle's organs? I don't want to put her through this if you can't make a guarantee. All right? Here's another one. I'm worried that somebody might overdose her just to get her organs. And I read about a case like that on the internet, California. So like our learners come out and say, this is more real than real, okay? Because these are the kinds of challenges they have. I mean, not all at once, but over the course of a day. Here's some other ones. Why can't we do this all in the ICU where we know everybody? Why do we have to go down to the operating room anyway? Or what if we change our minds at the very, very last minute? We just can't say goodbye. We just can't go through with this. What do you say? And are you absolutely sure that she is not going to feel any pain? And how about this? Can we meet the kids that are going to get her organs? Now, do you launch into a whole conversation that they may not even be kids that get her organs? She may not be able to be a donor? I mean, there's a lot of aspects to this, right? So what I'd like to do, I think I'm just supposed to click on this, and there we go. So here we are taking our actors and our simulator right into the operating room. And I just want to have you watch this for a few minutes. Okay. 19. The nurses had draped all the equipment prior to our filming, unbeknownst to us, because they wanted to make it a more human experience.
I think you're very impressive. I think you're doing great. Well, these folks are just getting Danielle settled in bed. I just want to ask you about her monitor. One of the things that we'll be doing is watching her monitor in an effort to be able to judge what's changing after we take out the breathing tube. And we expect her oxygen levels to change and her heart rate to change and her blood pressure. And that's our job, to look at those monitors. Now, you've seen those in her room for the past 5 days. And so one of the things that I would ask you is, do you want to be able to see that monitor to see what we're seeing? Or shall we just turn that away and we'll look at it, but you can focus on Danielle?
I think I'd like to watch. I'd like to know. I just want to know right away, I think.
Yeah, I feel the same way. Yes, I think we'd like to have the monitor then.
Okay. So first of all, remember that it's likely Danielle will take some breathing efforts, just like when we challenged her before to see if she would breathe without the ventilator putting in breaths. It's likely her body will still try to breathe, and so that breathing may become noisy, almost like a snoring sound. And it is normal as oxygen levels fall and carbon dioxide levels build up. When someone isn't breathing normally, it is normal for them to start trying to take deeper breaths. And those deeper breaths can look disturbing. They can look like gasps. And they can cause her body to lift and move as she takes a deep breath.
And does that mean she'll be in pain?
It does not. What that means is that her oxygen levels have fallen extremely low and her carbon dioxide levels have risen because she's not breathing well. And at that point, we also know that she'll be very deeply unconscious.
Okay.
And how otherwise will we know if she's in any kind of pain at all?
Oh, good question. We're going to give her some analgesics, some morphine, and some sedation with midazolam before we take the breathing tube out. So we can be absolutely certain that she's not experiencing any discomfort or any pain.
Okay. Good.
And we'll make sure that she's treated properly and that she gets medication so that she's peaceful.
Thank you.
Okay. All right. So the next steps are going to be that we're going to let you get closer to her, whatever position you want to be in, and spend a little bit of time. And then we'll go ahead and take off this collar, which we really don't need anymore, and take out the breathing tube.
Okay.
Okay?
That's essentially you pulling the plug at that point.
Well, the ventilator is what's actually plugged in. That's essentially us removing the breathing tube, which is attached to the ventilator. So she'll no longer be getting life support from that ventilator.
Okay.
All right.
Why don't you go get close to her?
Do you want to get in? Can I come around this side? Hey, baby. Hey, Daddy.
This goes on through the withdrawal of life support, and we have captured the whole thing. I think I'm going to stop here because I wanted you to see
She's
the actor
beautiful.
get into the bed with a mannequin.
Okay.
I can see where she gets her red hair. I'd like to go ahead and have Tony give some medications in preparation.
Okay. So I think that gives you a bit of a feel for, we've come a long way from just a wig, on top of the mannequin, but to really try to make the experience a more humanistic and whole one for our learners. And what I'd like to do is just wrap up with some of our efficacy findings about our program. We've published quite a bit. We've published and replicated our findings in the PICU, the NICU, and also cross-culturally in Italy. And so these are the findings. Again, this is self-report from our learners' perspectives. But we have pre- and post questionnaires for our learners, as well as 5 to 12-month follow-up outcome. And there were really 5 parameters that we were able to make a difference with for our learners, and they were that they felt more prepared, really from 99 to 93% over time. They left the session feeling much more prepared, and great, okay, 5 more minutes, thank you. And that was really sustained over time. Similarly, they felt that they had learned some important communication skills. Really, from 93 to 100% of them felt that even up to 12 months out that they still had retained those. One of the things I feel most strongly about is that they felt they were able to establish relationships with their patients. That's something hard to measure, but they felt that they had been able to move the needle in that regard. They felt more confident. Again, think about the lion. They felt more courageous about holding these conversations. They learned that they don't have to be perfect, but they need to be present. And that's a very big learning epiphany for a lot of people, because we tend to get hung up on the words, and it's really more about what's behind the words that patients and families remember. And also the reduced sense of anxiety was significant. This one we didn't make as much progress on, and for some learners, actually, they felt more anxious after the perks. And a lot of them would say things like, gee, I didn't realize it was so complicated. So for some people, actually, it might not be a bad thing. So the benefits of the intervention, of the learning, were not related to discipline. It was regardless of discipline, level of experience, or previous educational opportunities. The one thing where if people had a mentor, they tended to do better. Okay, so again, we built on some of that early learning. The people who had the most to gain from the PERKS program were those whose baseline level of skill, they rated themselves as lower. And 100% would recommend the program to their colleagues, which is always nice. And amongst our NICU sample, we asked them a very simple question 5 to 12 months out. We said, do you find yourself drawing on the program? This was a one-day program. 93% of them, up to a year later, said that they still find themselves drawing on the program. And 74% of them said that they had changed their clinical practice or their professional life as a result of the program. So here's just a few quotes from some of our learners. Just having the opportunity to practice this type of conversation was invaluable. We have so few opportunities to do that, and when we do, it's usually in an actual crisis situation. Another, I found the experience incredible and wish that I had done it sooner in my career. That was a 22-year veteran. I found that I could be direct and honest with families. I am usually so uncomfortable that I tend to skirt hard questions. The debriefings were so revealing. I thoroughly enjoyed it. This is probably my favorite quote. Remember the Harvard system, so I think this gives a little backdrop to it. In an environment that places an enormously high premium on advancing surgical and technical standards of care, it was refreshing to devote collective intellectual energy to cultivating the other half of the medical equation, the emotional standard of care. And what I learned is that one doesn't have to be perfect or have all the answers. One has to be genuine and real. I, too, have some sports heroes, and Joe DiMaggio happens to be one of them. And one of the quotes that he has is, there is always some kid who may be seeing me for the first or last time. I owe him or her my best. So what I'd like to say is that I think in terms of simulation and where we're going with the relational learning, our imagination is really the only thing holding us back. So there's endless possibilities for us and where we take this. I certainly hope that I've contributed just even a little drop to your learning in the course of this conference, and that you go forward and make those bookends and those conversations with your patients and families. I take this little guy with me everywhere I go when I ever do a talk. It's actually from a nursing recruitment bulletin from our hospital, but he reminds us that once upon a time you wanted to change the world, and you still can. One conversation at a time. Okay, so I just want to thank you again for your attention.